I think it will be important and it'll be a great refresher for all of us. So, you talked about the correlation between sickle cell trait and RMC. We're going to dive in deeper into that. But take us back. What is sickle cell trait? Give us that refresher. What is sickle cell trait? When we hear the term sickle cell trait, what is that even about?
Yeah, no, that's a fantastic question, and you're right. We need to start from the beginning. And so what happens is that there are many genes that control how your blood, your red blood cells, those are the ones that carry the oxygen around your body, the red blood cells. And there are many genes that control the shape of those red blood cells. There's one of them, one specific gene, which is called the beta gene. Mm-hmm. And each one of us has 2 copies of that gene. All of us have 2 copies. Now, if one copy of that gene has a mutation, a change, that's called the S change, then you have the sickle cell trait. If only one out of 2 copies have that S, the sickle mutation. If both copies of that gene have that S mutation, then you have the sickle cell disease. So that's it. That's the difference between the trait and the disease. If you have one mutation in one copy, you have the trait. If you have the mutation in both copies, you have the disease. Now, here is the interesting thing, and that's one of the things that led us to understand more about how RMC might happen to individuals with sickle cell trait. If you have the trait, meaning only one copy has that mutation, then the red blood cells normally will have the exact same shape as the red blood cells of somebody who doesn't have the mutation at all. So when I say normally, I mean while the blood is flowing around your body. And that is because the oxygen in most of your body is high enough so that the red blood cells stay on their normal shape. But what happens is that if you reduce the oxygen levels to very low, very, very, very low, then the red blood cells, even for somebody who has the trait, will change their shape. And instead of the normal round shape that they have, they will start looking like sickles. That's why this is called sickle disease. And so even if you have the trait under certain conditions of low oxygen, very, very low oxygen, the cells will sickle. Now, if you have the sickle cell disease, meaning both copies of the gene have the mutation, then the cells will have the sickle shape no matter what, no matter where they are in your body and no matter what the oxygen levels are. That's the key. That's what sickle cell trait is, and that's what sickle cell disease is. Now, somebody might ask, why was that even, developed evolutionary? And from our understanding, it seems that the individuals who have the trait may be particularly resistant to malaria. And so that may be part of the reason why the sickle cell trait and the disease in a subgroup of that population evolved to protect from malaria in areas where malaria may have high prevalence.
Yeah, I think that's again, when I think about sickle cell trait, to your point, it's just like anybody else, right? Red blood cells are flowing easily through the body, but under those extreme conditions, like you mentioned, certain complications can occur. I think to even take it a step further. So now we're kind of learning more about sickle cell trait, and we're learning that these potential complications, one of the biggest ones that we're learning today is RMC. So Doc, help us understand, what is RMC, renal medullary carcinoma, and why are we seeing it happen more in people with sickle cell trait?
Yeah, so renal medullary carcinoma, let's go from the name of it. So renal means kidney. Medullary means it comes from a part of the kidney called the medulla. And carcinoma is essentially the medical term for saying cancer. So it's essentially a kidney cancer that comes from the medulla. And what happens is this: the medulla is the part of the kidney that has by far the lowest amount of oxygen in the body. It's natural. It needs to have that low amount of oxygen. Otherwise, it's not going to function the way it's supposed to. Now, what happens is, remember what I told you, that if you have the sickle cell trait and under conditions of low oxygen, the cells will sickle, whereas everywhere else they will look round. So that's what happens in the medulla that naturally has low oxygen. The cells, the red blood cells in the medulla will sickle. So whether you have the trait or the disease, in the medulla, you will have sickle cells. That's the key. And so that's why we think RMC tends to happen so much more often in people who have sickle cell trait or disease. Very, very, very rarely, RMC can happen in people who don't have either the trait or the disease or any other blood disorder that can cause sickling. That's very, very rare, about 5% of all RMC cases. Now, RMC, as I mentioned, it's a kidney cancer, but it's very different from every other kidney cancer. That's why it's so important to raise awareness of it, because if you try to treat it the same as every other kidney cancer, you will do a big mistake. Because the treatments that work against most other kidney cancers do not work at all against RMC. It's like giving people water. It's like not giving them true therapy. And at the same time, the therapies that can work against RMC don't work against most other kidney cancers. That's why it's so important to distinguish between RMC and other cancers. And so RMC happens most often in young people, usually in their 20s, but sometimes even as young as 12, 8, even 3 years old, we've had one case. Sometimes older, the oldest we've heard is in the mid-60s, but usually is in the mid-20s. And it happens more frequently in men than women. And we can talk later about why that may be. And twice more frequently in men than women. And interestingly enough, and that's a whole separate story, it happens more often, 3 times more often in the right kidney. That's where it starts for. And unfortunately, it is a deadly cancer. The vast majority of people diagnosed with this cancer will have stage 4 cancer. So that means that the cancer will have spread. And it used to be that the average life expectancy from the diagnosis of this cancer was 3 months. Imagine, being in your 20s and having like a 3-month life expectancy from this horrible cancer. Now, that has improved. It went to 12 months, 18 months a few years ago, possibly now even 2 years. And we can even potentially, a small fraction, not enough, but a small fraction, cure them, eradicate the disease even at the stage 4 from their whole body. And we're trying to understand why we're able to do that for some people and not for others, so that one day we can get that percentage. It's 5 to 10% of cases now. We can get it one day to 100%.
Yeah. And again, to your point, it's one of the cancer that's really hard to treat. And I think what's unique about this cancer, as we continue to provide this education, is for people to remember that there are other types of kidney cancer that can occur, but RMC is different. I would love to get maybe a quick take or a quick input from your end. Sometimes we hear the term renal cell carcinoma, and sometimes you hear renal medullary carcinoma. Can you please help us understand what the differences or similarities are?
No, that's a great question. So renal cell carcinoma essentially means cancer that comes from the kidneys. And so renal medullary carcinoma does come from a part of the kidney, the medulla, as we discussed. So it is a renal cell carcinoma. So what happens is that the most common kidney cancer, 75% of all kidney cancer cases, are what we call clear cell renal cell carcinoma, essentially clear cell kidney cancer. That's what it is. And we call it this way because the cells look clear under the microscope. So 75% of all these cases. Now, the other 25% goes under the umbrella term non-clear cell kidney cancer or non-clear cell renal cell carcinoma, because the cells don't look clear under the microscope. Now, under that umbrella term, there are many, many, many different types of kidney cancer, renal cell carcinoma. And one of them is renal medullary carcinoma. So essentially that helps you pinpoint what this is. We have renal cell carcinomas, kidney cancers. We have the clear cell and the non-clear cell. And from within the non-clear cell, RMC is one of these types, but there are many others.
Nice. I'm glad we can get that differentiation, because we hear that those terms being used sometimes even interchangeably. So thanks for providing that. And again, for everyone joining us, please feel free to put your questions in the chat. I see some questions already coming in, so we're going to be tackling those shortly. I want to ask a quick follow-up. And so we've kind of talked about sickle cell trait and renal medullary carcinoma, and these numbers tend to be higher, and even for people who are much younger. Is there a specific reason why we tend to see RMC specifically for people with sickle cell trait?
Yeah, man, that's a fantastic question. And, it's a question that we've thought about a lot because, initially, let's say 5 years ago, we were seeing the vast majority of people who develop RMC have the trait. And we were wondering, well, why do we see it in the trait and we don't see it as much with the disease? But then that's when it came to us. And we realized what I told you, that if you look at the medulla in particular, the cells will look like sickles, whether you have the trait or the disease. So for the environment of the medulla, it's all the same, whether you have the trait or the disease. And now, if you start thinking about it this way, you will realize that if we assume that since they look the same, that you have the same risk of developing RMC, whether you have the trait or the disease, then the sheer numbers of sickle cell trait are so much higher than the disease. There are 55 times more people who have the trait versus the ones that have the disease. That's the actual number. So if you think about it, for every one patient who has the disease and has RMC, we would expect to see 54 people who have the trait and have RMC. You see what I'm saying? And so if you start thinking that it's the same risk factor, then the numbers make sense. And indeed, when we looked at it, we realized that, there is no clear difference in the incidence, in how often RMC happens, whether you have the trait or the disease. That's what helped us connect the dots, that this is not something genetic, because, we're thinking, maybe those with the trait have something genetic, but that didn't make any sense, because if that was the case, we would be seeing RMC cluster, let's say, in families, and we've never seen that. It doesn't happen, in particular families. And so none of those things made sense until we realized that the risk should be about the same, because it's a disease of the sickling of the red blood cells, and that's what can damage the medulla. It's kind of like, how smoking can damage the lungs. It injures the medulla, and it's that injury that can cause RMC.